full name and designation, please?
Full name, Jonathan Romel Daniel. Nobody knows the Jonathan except in my postgrad in the UK, where people called me Jonathan, but everywhere I'm known as Romel Daniel.
And your designation?
I'm a consultant cardiologist and internist and I've worked in all three hospitals, St. Jude's, Victoria Hospital. I've done a stint in OKU, but predominantly now I am wholly and solely in Medical Associates Tapion Hospital. I'm also one of the directors of Medical Associates.
So as much as possible, answering complete sentences because only your audio will be heard, okay? Give us an idea of what happened over the last 2 days.
So what has happened really is we have tried as much as possible now to elevate the standard of care, of medical care in St. Lucia. And in fact, perhaps what I said is not quite correct. It's not now. We have been doing this that's why Tapion Hospital in the first case was established. And so we have a cadre of persons who have come in determined to make an impact, a significant difference to the quality of care delivered in St. Lucia. And we have been able to do it because of the facilities we operate in. Over the last 2 days, what we have done is do angiography, which really started from about October last year. But we only did angiography last year, which means putting dye into the heart. And the reason why we put dye into the heart in an invasive procedure is for those patients who are having angina, who have had a heart attack, usually there is a disconnect between supply and demand of blood because the heart itself needs food. And because of that, sometimes the flow in some of the coronary arteries, which supply the heart with food, is inadequate. And with the coronary angiogram, you can see what is happening. You can see what the narrowing is, whether you can intervene. Up to last year, we were not able to put in stents, a balloon and stent, which would be a definitive procedure after the angiography. But over the last couple of months, and it was an excellent team approach, I think led by Dr. Snack and Deborah Spencer, our pharmacist. We have been able to procure a significant amount of supplies to enable us to take the next step forward, which is to be able, if we need to do balloon and to balloon the arteries and also put in the stents if we needed to do that. Now, not all patients who have an angiogram will need ballooning. Not all will need a stent. But this is a major leap forward in the ability to do that. For example, the patients we did on this occasion, they had diffuse disease. There was not a critical narrowing except for one where the artery was kinked. And because of that, it was thought not wise to put in the stent because sometimes the arteries were so narrow, the possibility also is you can have complications. Stents can rupture. So it was thought that the best thing to do for this patient and for all the patients, which we did over this weekend, was to just continue medical medical treatment, treat their risks. Which brings me to the next point. Because you have a facility available to do the stenting, to do the ballooning, doesn't mean you should do it. You should do what's the ethical thing. And if it is not the right thing to put in the stents, to do ballooning and put in the stents, you should not do it. And I think that was the guide which we operated by this weekend.
So I want you to explain to the average man on the Trotton bus, what is ballooning, water stents, and why is it critical? Why is it so important that, or beneficial that the service is available in St. Lucia? I want you to speak to the prevalence of heart disease, heart attacks, the capability, and the fact that they no longer need to travel.
Yeah. So what we have in St. Lucia is a significant proportion of our patients are diabetic and hypertensive. Especially when you're diabetic, it promotes dyslipidemia, meaning the cholesterol is not well controlled. And all of these lead to what we call plaque formation. In other words, you have gunk forming within the arteries. And of course, if you dovetail that into the fact that a lot of people drink a lot, they don't exercise, they eat badly, then you have a recipe for disaster. But in addition to that, I have found that more and more of our folks, because of stressful situations, are actually coming in with having been tipped over into cardiovascular disease. It can be a stroke or it can be a heart attack. So for the average person, what I want to say is that, first of all, primary prevention is necessary. That's the first thing. Then secondarily, if somebody were to have a heart attack, we have now the ability to treat it. What we did before was, and it is also available in some of the other hospitals, we were using what we called a thrombolytic, which is a clot buster. Now we have gone a little further. So for chronic diseases, we can, and patients who have an acute heart attack, we can use the thrombolytic, but in addition to that, we can go in shortly afterwards and dilate the blood vessel. Remember what I said, it's plaque formation that narrows the blood vessels. So you may have a little bit of damage to a blood vessel, and what we call platelets come in and block that vessel. That's when people get an acute heart attack, and some of them are very, very bad. And there is a saying that minutes mean myocardium, meaning the longer you take to get to the hospital, the longer you take to pop in some aspirin, the longer you take to pop in another medication called Plavix or clopidogrel, the more damage ensues. You need to get in as soon as possible. But having said all of that, then what we have in addition to that is that now this part has been dealt with. Now we are seeing about doing the angiograms, which it's really putting dye into the heart. And you can do it through the groin, but now most times we do it through the radial artery, through the wrist. And so we direct these catheters into the coronary arteries which feed the heart. We put in dye and see whether there is any narrowing. And if there is any narrowing, then what we do is we use a little balloon, and if it is amenable to that, we use a balloon, open it up, and then put in a stent, which is like a bridge, which allows blood to cross from one side to the other. That's basically what it is. So there is tremendous potential with that, because not only can we now do it, what we also, and some of it may not need to be done, so far what we will do them on a non-emergent basis, the angiogram, right? But we will work ourselves to doing it on an emergent basis. But with an emergent basis, the problem is that you have to respond within 90 minutes. So you understand the difficulty if you have so many other issues to deal with and you do not have the necessary backup, then that becomes a problem. But we'll work ourselves to that. The other thing I should mention is that a lot of our people are not able to do the amount of work they should be doing over a particular period of time. I'm talking about So NIC becomes particularly affected with patients who have to have amputations because their diabetes has not been controlled, because their diabetes and high blood pressure, the chronic diseases. We have a major issue in St. Lucia about that, whereby the blood vessels are not being supplied. So the next step, after having done these, what we are doing now is to see whether we can stent the arteries in the legs. And with that, I expect us to be able to improve the productivity in St. Lucia. That is the aim. That is the aim. So you are less dependent, people become less dependent on early retirement from NIC. If we can get people productive still, then I think that's a major boon for the economy of St. Lucia.
So this is available in St. Lucia now. Tell me what existed before and how this will be beneficial, not just to St. Lucia, but the rest of the OECS.
Yeah. Well, there are some things I recognize that, and I've recognized it a long time. So I also used to do a lot of work training with the guys in continuous training with the guys in Martinique. And I realized some people from Martinique were going to France. As much as the quality of care in Martinique was the top class, there are cultural things that you can never get over. So there'll be some people, no matter the level of your expertise, they will choose to go to Miami or go to Martinique. I do not have any issue with that, but I do not think that we need to validate our expertise, because we really do have significant expertise in St. Lucia. But for those people who believe in us, and there is a significant number of people who do. Whereas before, on a non-acute basis, we would get patients to go into Martinique, not just to do the angiograms, but for the angioplasties. In fact, let me reverse that. Not just for the angioplasties and the stents, but for the angiograms, the coronary angiograms. I think now we have made a significant dent to decreasing the possibility of that happening for those people who would welcome that. I think that from the point of view of costings, from the point of view of having your relatives nearby, from the point of view of being able to go home within 24 hours, or sometimes the same day if it's done early enough, I think that this is a significant, in fact, I think this is a massive improvement in healthcare in St. Lucia, what we are able to offer now. And I think that the next step, of course, would be to educate persons as to the possibilities, but at the end, they will have to make up their mind, this is what they want.
Dr. Daniel, you're making my job difficult. You're making my job difficult with my questions. Now, I'm asking the question again. I want you to sell to me, okay? Before, I understood everything you said. Me. I need 30 to 45 seconds. You give it to me at the end, with going home, confidence in
Yes.
the team, but I need you to sell this to me, local and regional.
Yes.
This is a significant step for the hospital and for medicine in St. Lucia.
Yes.
Speak to the common man, travel overseas,
Yes.
and our regional neighbors as to what is available here.
Yeah. So, for the common man, for our St. Lucians, and for anyone, the big advantage of Medical Associates Tapion Hospital is that a lot of people know the physicians. They have confidence in the physicians. They know that they can have a discussion with the physicians, and it's not in a different language. In addition to that, there is difficulty in many cases in traveling overseas. In many cases also, the cost may be excessive, or could I say, not necessarily excessive, but exorbitant, all right? So with all of that in mind, if for the society, the St. Lucian Society, we're able to develop this possibility, I expect for persons to recognize that their relatives will be near them, they will have the necessary expertise, they have the ability to speak to their physicians, their own physicians. If they have any concerns, that would be dealt with. I expect that to be a significant enabler of persons deciding that this is where they want to be. Now, for our neighbors, all those people in the OECS countries, I am not aware of a cath lab facility being available other than in Trinidad, Barbados, and in Jamaica, of course. Okay, I'm talking about the English-speaking Caribbean. Of course, we know that Cayman has Help City, which is, we know that's a phenomenal group. But for Dominicans, for example, I expect them to prefer to come here. In fact, it's already happening as regards quite a few cases that we are doing right now in St. Lucia for Dominican patients. So I expect that within the OECS, that the closeness that we have, the discussions that we have with some of our colleagues, where they have already been referring quite a few patients to us, I expect that to continue and in fact increase because of the standard of care, the level of care that we are offering in St. Lucia.
My final questions. In your 4 cases, which one was the most challenging or surprising?
I would think the very first one, the very first patient, because what we saw, first of all, setting up the theater, you need, when it becomes very, very routine, so when you have the second case, the third case is much faster, okay? But this particular patient, a really lovely lady, she had a particular kink in one of the coronary arteries, and we were looking at it over and over and over again to see whether it was amenable to be stented. And we realized that it was not, that the arteries were too narrow. But that basically was it. That one was a little difficult. But I would say that because of the amounts that we do, and we expect to be doing them virtually we will do them to start with every month initially, and I expect us to be able to do them at least every 2 weeks, maybe, and then maybe come down to every week. But we will also recognize, you will also recognize that all patients present a different problem. And with that, we have to decide which patient is what we would stent and what we would not stent. We have made a decision on this occasion with all our patients, although we have the ability to stent, not to stent them.
Greatest lesson learned over the last 2 days?
I think that the greatest lesson is that nothing can be achieved without a team. Nothing. If you want to go fast, you go alone, but if you want to go far, you go with a team. And nothing that we have achieved over the last 48 hours would have been possible without everybody. I'm talking about the executive branch of Tapion Hospital, the board of directors, all our nurses, and also the physicians who, for example, had to hold on for us while we were doing these. But it would be remiss of me if I didn't mention Dr. Julien Fabre. He has been an excellent proctor, excellent proctor. He's the one we normally refer our patients to also. But he has been truly an excellent proctor. And I think when we work as a team, when we make sure that we have cooperation with the other islands, when we make sure that the Caribbean Cardiac Society, within its ambit, within the ambit of the French with the University Hospital in Martinique, we continue to establish cooperation with them. I think the sky is the limit as to where we will go to. In fact, beyond the sky, I think we can achieve a great deal.
Tell me your full name and designation one more time.
Jonathan Robel Daniel, otherwise known as Robel Daniel.
Thank you very much.
Welcome, thank you.